Welcome. I'm Dr. Ogan Gurel. This is Insights in Medicine, brought to you by InTimeTV. We have another great hour ahead of us with a fabulous guest who has appeared on a number of public shows and so forth, and we're really honored to have her. Our guest today is Dr. Annabelle Volgman. She's a cardiologist, director of the Rush Heart Center for Women, and it's great to have you. Let me give a little bit of background on Dr. Volgman. Many of you may actually have seen her and heard of her work, but she's from New York City and graduated from Barnard, part of Columbia University, in biology with a minor in chemistry. Graduated from the College of Physicians and Surgeons in New York, my alma mater as well, and came to Chicago for residency in internal medicine at the University of Chicago, and did her fellowship in cardiology with a specialty in electrophysiology at Northwestern. And since then, still in Chicago, has been at Rush as an attending for the past over 18 years, and is presently director of the Rush Heart Center for Women. So great to have you, Dr. Volgman. Can I call you Annabelle?
Yes, of course. Thank you, Ogan. It's a pleasure to be here.
And the topic for today is women's heart health, issues in women's heart health. Obviously, you're an expert in the area, but it's an evolving field and one in which general practitioners, cardiologists, and there's a lot of new information. So what we'd like to do in this hour is really develop this topic and learn your insights.
Well, as you know, the Framingham study has given us a lot of information about heart disease and what is the cause of mortality and morbidity in the people in the United States. And as I'm sure all of us know, the Framingham study was started in the 1948 after Franklin Roosevelt died of a stroke, and nobody really understood what caused his stroke. And as a result of that, the Framingham study was started in the 1950s. So in the 1950s, people in the Framingham town were being followed. And in the 1970s, 20 years later, those 20-year-olds that were being followed started having heart disease. Men were dying of heart attacks. And what they noticed was that women were not dying of heart attacks.
Right.
So I think all of us were misled that heart disease was a man's disease because of that study.
In terms of the initial results from that study.
Initially, yes. But then 10 years later, the Framingham study again reported that women were now starting to die of heart attacks. So it was the women in their 50s. So there's that 10-year gap that really is so important because it made us all think that heart disease was only affecting men. But those 10 years made a huge difference. Women started to smoke. Women didn't take care of themselves. They thought that they were immune to this heart disease, so they didn't take care of themselves as much.
So it's not just the aspect of heart disease occurring later in women, but to some extent, the initial studies created a framework that perhaps women were not protected as much through the lifestyles and so forth.
I think that really played a big role in what has happened in the 1980s, because I think women started to take care of their husbands, but they didn't really take care of themselves in terms of high blood pressure, diabetes, cholesterol. They let themselves go. They didn't exercise as much as the men did. So that we now are seeing that since 1984, there are more women dying of heart disease than men. Mm-hmm. And since then, the gap has just widened. So that since 1984, more women are dying of heart disease, and now 70,000 more women are dying of heart disease than men. And we were educated in the 1980s. You and I are about the same age, so
right.
We were told heart disease is a man's disease.
Well, not only that, but I think there's an interesting concept back then that female gender was in fact protective against heart disease. Am I misquoting? I mean,
no, and that was because women weren't having heart attacks until their 50s, so they thought it was protective. But what we're seeing now is a big change in the demographics, because women started smoking, and women started getting hard jobs that were very stressful,
type A, stressful,
high-powered lawyers and businesswomen, and I see it in my practice all the time, that the tremendous stress that they're under is really affecting their hearts.
Right.
And they have palpitations, they have chest pains, their blood pressures are higher, they're not exercising, so they're increasing their weight, and they're just more sedentary because they have to work so hard. And as a working mom, I know how it is. It's hard to get your exercise in, take care of your kids, take care of your husband, and take care of yourself. And you're always going to be the last one in that list, unfortunately, for women. So we've been seeing that trend.
Definitely. I mean, that's the statistic you said, 70,000 more women. My understanding also is that more women were dying of, and we'll explore this in more detail later in this hour, but more women were dying of heart disease as a function of them living longer. How has that statistic been extricated from the risk of heart disease?
That's right. That's a very good question. First of all, there are more women than men in the United States. There's 51% more women. So naturally, there are going to be more deaths. And as the women live longer, they're going to tend to have the diseases of old age, such as heart disease, hypertension, but also cancers.
Right.
So what we're seeing, though, is that there are younger and younger women having heart disease at this point.
So the relative risk is not as disparate as it would have been indicated originally by the Framingham study.
Yes, that's right. I think times have changed and the risk factors have changed. You see more obesity in women. You see more diabetes in women. And actually, there was a study that was just published a few weeks ago that showed that diabetes is, men with diabetes have seen a decrease in their mortality in the last few decades. But there is no decrease in mortality in women with diabetes.
And mortality from cardiac causes or overall mortality?
From cardiac mortality, right. And that's the #1 cause of deaths in diabetics.
We're going to take a break shortly, and what we'll talk about as soon as we return are some of these risk factors. But I'd also like to get into, because of this, I should say misinformation, but confusion as a result of the Framingham study, what is being done to change that perception? Okay. So we'll talk about that after break. I'm Dr. Ogan Gurel, our guest, Dr. Annabelle Volgman. Stay right there.
I'm a lion!
Yes, you are. Come here. Let's see how this looks.
Hey, how's my little horse?
She's a lion.
Yes, she is.
You don't have to be perfect to be a perfect parent. When you adopt a child from foster care, just being there makes all the difference.
Come on! This way! Who is that guy? I don't know! Hurry up! He's right behind us! I know! Come on, get up!
407 years ago.
Think history is a little scary? Then log on to LOC.gov and see how much fun it can be. The Library of Congress at LOC.gov.
Pants, pants, pants. I am folding the pants. The pants are long. Do they go on my head? Do they? Do the pants go on my head? No. They go on.
Everyday moments can become teaching moments because learning starts long before school does. Give your child the start they need at bornlearning.org.
I wish I could go back. Back when I didn't need someone to do my hair. Back when I could still say my husband's name. Back when I could have called 911 but didn't. Back when I first felt the warning signs of a stroke but did nothing. I wish I could go back, but I can't.
With a stroke, time lost is brain lost. At the first warning signs, take action immediately.
Welcome back. I'm Dr. Ogan Gurel with Insights in Medicine, brought to you by InTimeTV. Our distinguished guest, Dr. Annabelle Volgman, Director of the Rush Heart Center for Women. During the past segment of the show, we just learned about the Framingham study and how the early results in the 1960s, 50s and 60s indicated a significantly higher relative risk for men. So as a medical community, we latched onto that, the medical textbooks, everything, and then...
Cigarette companies?
Yeah.
Targeted women to smoke?
Well, that's a whole other topic.
Yes.
But to some extent, then in the 70s and 80s, there was a significant shift, and women started to get more heart disease and so forth. And we went through some of those statistics. What I'd like to explore a little bit, Dr. Volgman, Annabelle, is what are some of the efforts being done now to literally shift 180 degrees? Generations of physicians have been taught otherwise.
Well, several health care institutes, such as the American Heart Association and the NHLBI, the National Heart and Lung Blood Institute, have really made a huge effort to educate not only the physicians, but the lay public about heart disease in women. And it's to the point, actually, that the men feel a little neglected, but don't worry, men have been studied for many, many generations, and we continue to study them. But I think we need to learn more about women because they don't respond the same way to our treatment. They don't respond the same way to our technology. So we really need to... And
the diagnostic aspects are different?
Absolutely. And the disease itself is different. The formation of coronary artery disease or atherosclerosis is different in women than in men. Women tend to deposit their plaque circumferentially, and men deposit their plaque eccentrically, so that it's much more obvious in an angiogram that a man has coronary artery disease. But women are very deceiving because they look like they have smooth arteries, but the plaque burden is there. So if you do an intravascular ultrasound, it would show that that woman actually has atherosclerosis, but it doesn't look like it on an angiogram.
So IVUS, in a sense, would be more appropriate for women than conventional angiography?
I would say if a woman who has typical symptoms with coronary artery disease has persistent chest pain, and you really want to know whether she has atherosclerosis, you can do one of many things. One is do an intravascular ultrasound, IVUS, or do a 64-slice CT, which can also look at that. But also there are markers such as the HSCRP, the high-sensitive C-reactive protein, which can give us an idea of whether they have intravascular inflammation.
Right.
If that's elevated, another way is actually a carotid ultrasound. If that shows atherosclerosis, you've got your diagnosis. You have to treat that patient.
Which is likely in the coronaries.
Absolutely.
Let's talk about diagnosis a little bit later. I wanted to talk first about the risk factors.
Yes.
We have the concept of the various risk factors, hypertension, smoking, lack of exercise, so forth. But apparently those risk factors are actually different in women than men. Can you tell us a little bit about that?
Diabetes is a worse risk factor for a woman with diabetes for heart disease because we see that the risk for a woman with diabetes is almost 2 to 3 times worse than it is for a man. So a woman with diabetes...
The risk for coronary artery disease.
For dying of heart attacks or dying suddenly, a woman with diabetes is worse off than a man. Hypertension is an equal opportunity risk factor, so it doesn't tend to make it worse for women.
It's fairly gender neutral.
It's in a way, although older women have a higher systolic blood pressure, so they're more prone to strokes. And we don't know why. Women have more systolic hypertension, especially in the elderly population. The SHEP study showed that. Cigarette smoking is worse for a woman.
Right.
3,000 toxins every time a woman inhales it. They can't get rid of it as easily as a man can, and they can't stop smoking as easily as a man can. So it's a worse risk factor for women, cigarette smoking. Lipids, totally different, risk factor. High triglycerides, a woman just needs to have a triglyceride over 200 to have a risk for heart disease. But a man, it doesn't really give them a risk unless it's over 400. So women are much more prone to heart disease if their triglycerides are slightly elevated.
So in a sense, those published numbers needs to be more finely nuanced relative to men or women.
Yes, I think so. I think we need to concentrate more on who should we be more aggressive with. And it's very simple to actually treat high triglycerides with diet, exercise, but there are certain medications that could do it. But I think the best thing we can do for our patients is to really strongly encourage them to decrease their simple carbs and to make them exercise and lose weight. That will usually take care of a lot of high triglycerides. The other risk factor is
there
low.
a difference in the LDL, HDL parameters between men and women?
High LDL is an equal opportunity risk factor.
Same thing, gender
but
neutral.
HDL is another bad risk factor for women. If a woman has HDL less than 30, it's a sure sign that they're going to have atherosclerosis.
And the number for men would be? I know you're an expert in women's health, so I don't mean to put you on the spot.
A man should have HDL greater than 40. A woman should have HDL greater than 50. So if you look at the women who have HDL less than 30,
that's a problem.
That's a big problem. But men are also in trouble. If their HDL is less than 30, it's a sure sign they're going to have atherosclerosis. So we really need to hound these patients to exercise, exercise, exercise.
Well, it's interesting. That's almost like, in a sense, a level of personalized medicine.
Absolutely.
Not maybe personalized in the fancy genetic, genomic sense, but personalized to the extent that it's not just this gender-neutral recommendation, but personalized to between men and women. And what's interesting, I think compliance always is a challenge when it comes to patients. So it's important, I think, so you don't cry wolf, that you don't say, well, you need to exercise every day, not eat this, eat that, not eat that, etc. But if you can fine-tune that, I think the message becomes more effectively, especially if you can indicate that it's specific for your gender. We're taking a break. This is a fascinating hour we have with Dr. Annabelle Volgman and Dr. Ogan Gurel with Insights in Medicine, brought to you by InTimeTV. We'll be right back shortly.
Once they've outgrown their toddler seat, they're still not ready for adult safety belts alone. 4'9" is the magic number. Until then, kids need a booster seat. Make sure your little pumpkin gets there safely. Visit boosterseat.gov.
Protect yourself from mannequinism. Volunteer. Vote. Stay informed. It's easy to get involved.
Can I ask a few questions about the apartment on Park Street?
What was your name?
My name is Juan Hernandez.
It's been rented.
Hello, my name is Sanjay Kumar. I am calling about the apartment on Park Street.
It just rented.
My name is Tyrone Washington. I'm calling about the apartment for rent on Park Street.
It's not available.
I use a wheelchair and...
It's gone.
Hello, my name is Graham Wellington. I'm calling about the apartment for rent on Park Street. Is that still available?
Yes, it is.
Oh, it is?
Housing discrimination is illegal. If you think you've been a victim, call us.
Before you start an online relationship with a guy, think about how it could end.
Welcome back. I'm Dr. Ogan Gurel with Insights in Medicine, brought to you by InTimeTV. Our topic for today is issues in heart disease in women. And our distinguished guest, Dr. Annabelle Volgman, director of the Rush Heart Center for Women. And just before the break, we were talking about risk factors for women and how those are actually different in terms of diabetes being more of a significant relative risk for women than men, actually hyperlipidemia having nuances that are more significant for women, and so forth. If you would, we'll move on to diagnosis that's different, but just summarize your views on the risk factors.
Well, as you said, diabetes is a bad risk factor for women. I think it's very important for people to realize that they can prevent diabetes. The metabolic syndrome is our way to figure out who's going to develop diabetes. We call metabolic syndrome the pre-diabetes syndrome, so that if your waist is over 35 inches and your blood pressure is just a little bit elevated, it may not need medications yet, but it's getting there. So if it's over 130 over 85, that's another risk factor for metabolic syndrome.
130 over 85,
is the blood pressure.
Oh, the blood pressure, yeah, okay. Yeah.
If it's over 130 over 85, that's another slight risk factor. It's not going to be a risk factor for coronary artery disease, but it is a risk factor for metabolic syndrome. And of course, the body mass index. If a patient is obese, where the BMI is over 30, that's another risk factor for metabolic syndrome. If they have these and their HDL is low and triglycerides are high, they've got the diagnosis of metabolic syndrome. I can guarantee you in less than 5 years, that patient will be diagnosed with diabetes. So this is the stage we should be really concentrating on helping that patient to realize that if they don't do anything about their weight and their sedentary lifestyle, they are going to develop diabetes. And what's really heartwarming to see is that when I talk to my patients about that, it really frightens them. Nobody wants to have diabetes. And I think we need to empower our patients to know that they can do something about preventing diabetes.
Right.
I think a lot of people think, oh, I've got diabetes and I don't even know how I got it. Well, we can tell them, this is how you cannot get diabetes, by exercising and by losing weight and eating the right foods.
So a large part of your practice, obviously, is around preventative
Absolutely.
measures. But to some extent, unfortunately, some patients get to the point of diagnosis.
Yes.
How is diagnosis different between women and men when it comes to heart disease?
In terms of blood tests, we need to get the same things. Fasting lipid panel. I usually get an HSCRP so that I can be guided to how aggressive I should be.
C-reactive peptide.
The high-sensitive C-reactive protein. The way I use that is if I have a patient who has some risk factors. I use that to help me guide how aggressive to be with that patient. Should I start them on a statin that will lower it to less than 70, to lower it less than 100? Where should I be with that? So if the patient has several risk factors and an elevated HSCRP, I will use that HSCRP as I'm treating the patient. If I still haven't gotten that HSCRP, I will be much more aggressive with the medications that I'm using. In terms of other diagnoses, I usually will get some imaging with a stress test. And there are some studies that are showing that ECG is sensitive enough, but I think for the most part we all use some imaging, especially for women. This is another very little known fact that estrogen is very similar to digoxin when it comes to the ECGs.
Interesting.
So estrogen and digoxin actually make the ST segment react in a way that makes it non-specific on the ECG to interpret for the stress test. So there's a lot of false positives.
So in a sense, again, I don't want to jump the gun, but would you say that imaging may be relatively more important for women than men?
I think it is. I think
again,
it is.
We don't quite know, but
Yes.
to the extent that the ECG can have this non-specificity,
That's right.
your threshold to go to imaging may be lower.
Yeah, it's probably, if you look at cost effectiveness, you probably could just get away. You know, there's, again, clinical judgment here. If there's a lot of risk factors, I would go with imaging, because my suspicion is going to be high that there's going to be coronary artery disease. Right. So I want to know what I'm dealing with, and I'm reassured if a woman's SPECT imaging is negative or the echo is negative. However, I think we need to always look at the whole picture.
Of course.
Because even if the SPECT is negative, there are false negatives. And unfortunately, there are some women who have been misdiagnosed as not having coronary artery disease, and then they go ahead and have a heart attack, if not dying. And those are very rare, I agree, but I think we need to be very careful.
So you had also mentioned during the last segment this very interesting phenomena that plaque deposition in women is more equally circumferential than with men, in which plaque deposition is often more eccentric.
That's right.
So that would mean that their angiograms look better in a false negative sort of way.
Absolutely.
So that's interesting, because the ECGs as a screening test have a higher degree of false positives, relatively speaking, than the imaging has a higher degree of false negatives. So the diagnosis of coronary artery disease in women
is very difficult.
Very difficult, exactly.
Yes, and it drives us crazy, because I
don't think this is commonly understood.
No. And it's only in the last few years. Actually, Dr. Steve Nissen has been talking about this for years, but in light of the new WISE study, Women with Ischemic Syndrome evaluation study, we're finding out that women who have persistent chest pain, despite negative angiograms, have a worse prognosis than somebody whose chest pains go away. So even if they have normal coronary angiograms, if they have persistent chest pain, they do very badly. So we need to take care of those women who have persistent chest pain
so the clinical
and not ignore them.
symptomatology becomes very important.
Very important. And like I tell my residents, I treat the risk factors. I don't treat what I see, I treat the risk factors.
Well, we're going to get back to that a little bit more right after the break. I'm Dr. Rogan Gurel. Our distinguished guest, Dr. Annabelle Volgman, Director of the Rush Heart Center for Women. This is Insights in Medicine, brought to you by InTimeTV. Stay right there.
Two words for you. Pop quiz. Ready? Name any funny movie. A drama. Name a mystery. And one more thing. Name the movie your kids saw today in science class.
Know what really matters. Know about your kid's school. And know about your kid. Find out 100 ways to know more, do more.
There's something about you, baby. I can't get enough. There's something about you, baby. I got you looking at me, I'm gonna call you bluff. There's something about you.
The smallest moments can have the biggest impact on a child's life. It takes a man to be a dad.
To the morning light.
Listen to smoke before you give it a try.
Only you.
Don't play with matches. Don't play with fire. Cause there's nothing very funny about Rick Downright. Nothing very nice on a homeless mind. So if a gorgeous force is what you desire, don't play with matches. Don't play with fire.
Only you can prevent wildfires.
Fire.
Mom?
Dad?
How long should I wait for you?
If I'm at soccer practice.
What if something happens? Will you come get me?
There's no reason not to have a plan in case of an emergency.
Should we go to the neighbor's house?
And some extremely good reasons why you should.
Can you tell me?
Talk to your family about what you would do in case of an emergency.
Welcome back. I'm Dr. Rogan Gorel. This is Insights in Medicine, brought to you by InTimeTV. Our guest, Dr. Annabelle Volgman, Director of the Rush Heart Center for Women. We were talking in the last segment about the diagnostic challenges and differences between women and men, and the utterly, I think, very challenging realization that in terms of ECG as a screening modality, there's a greater sense of false positives because of the estrogen effect and so forth. And then when it comes to the definitive diagnosis relative to angiography, there's because of the more even circumferential deposition, there's more false negatives.
That's right.
So to some extent, one may say, as we actually talked about during the break, that these diagnostic challenges may also account for the very high death rate.
Absolutely. I think that we need to get better at diagnosing coronary artery disease in women, because a lot of people out there are being misled that when they have a negative coronary arteriogram, they have no atherosclerosis.
Right.
And that may be completely misleading the patient into not taking their statins, not taking care of their diabetes, not taking care of their high blood pressure. So I think physicians really need to know that even if they have negative coronary arteriograms, if they have persistent chest pain and if they have a lot of risk factors, they still need a lot of that risk modification.
Right.
And in that Y study, the best thing they could have done was to tell that patient to exercise, and it helps with their chest pains.
Well, we were talking before that to the extent that the angiograms, the arteriograms are, again, they're still a gold standard of sorts, but they have a challenge with respect to women. But we had talked about the clinical symptomatology being important. And then also, previously, we talked about IVUS, intravascular ultrasound.
That's right.
Is it really feasible to have that as the mainstream technology?
Unfortunately, a lot of cardiologists don't like to use IVUS. It's cumbersome. It adds some time to the angiogram. So in a busy cath lab, they're not going to want to do it. So I think that's fine.
But there is a reimbursement differential.
There is, but not everybody likes to do it. So, you know, I'd like to be idealistic, but I think realistically it's not going to happen. One good modality is the 64-slice CT, and in the future the 128-slice CT, which gives us very good images of the inside of the arteries of the heart of men and women. So I love the 64-slice CT in terms of diagnosis.
When it comes to the angiography wars, namely the CT angiography versus the coronary arteriograms, that may not necessarily be the question, whether one is better than the other. As we were saying about personalized medicine, one may be better for women and the other may be better for men.
Yes and no.
Okay.
The one bad thing...
it's simplified.
But no, the one bad... It has nothing to do with cardiology, unfortunately. The one bad thing about 64-slice CT is it has the equivalent of 100 chest x-rays directly to the breasts.
So breast cancer, exactly.
Breast cancer.
It's always
and
more
that is the number one fear of women. It's not their number one killer, but it's their number one fear.
So significantly more than digital radiography in terms of the angiogram?
An angiogram is about the same, actually. It's about 100...
right. So to that extent...
But what happens is if you get a positive CT angio, you're going to get a coronary arteriogram to verify it, and then to do an angioplasty. So that's 100 chest x-rays for CT angio, another 100 chest x-rays for... So I think we need to be very careful.
Yeah, of course.
And we need to really make sure that it's not something that everybody's going to go out and get without thinking about the risks.
Right.
So for my high-risk breast cancer, women with high risk for breast cancer, I really tell them that, you know, we may not be getting enough benefit for the exposure to the radiation risks that you're going to get with this. And more often than not, they won't get it.
Right.
So I just treat the risk factors. Again, I just go back to treating the risk factors.
So our audience has a lot of general practitioners in internal medicine, primary care doctors and so forth, although certainly we have cardiologists in our audience. But to the extent for the general practitioner, as well as to some extent for the layperson, how would you summarize this whole diagnostic conundrum, the differences with women, and at a very high level, every patient's different, your recommendations?
I think that we need to go by, of course, individualized care. But if a patient is symptomatic, I would treat them with medications first, because those are the mainstay of medical management, of therapy. Those medications have been proven, study after study, to decrease mortality and morbidity. Angioplasties have never been proven to decrease mortality, ever.
Right.
So,
and in fact, drug-eluting stents haven't improved on that either.
Exactly.
But to the extent of the diagnostic aspects, we'll get to therapies shortly, but from the diagnostic perspective, what would you summarize?
So for diagnostic purposes, I would only do a stress test and an angiogram in a symptomatic patient.
Okay.
Because if they're asymptomatic, you just treat them with medications. Treat the risk factors. If they're symptomatic, then the risk is worth the risk of doing an angiogram, risk of doing an angioplasty is worth the benefit that you could gain, because it does decrease chest pains and it does help the patient live their day-to-day lives.
So I guess the take-home message would be that obviously risk factors need to be treated in both sexes, but the risk factors need to be treated even more aggressively, particularly with diabetes and the hyperlipidemia in women.
Yes.
And then to the extent that the symptomatology is more, the symptoms are more significant in women, those need to be treated more aggressively.
Absolutely.
And some of the other technologies and modalities, because of the breast cancer complication and the false positives, false negatives, to not be as dependent on them.
That's right.
Let's go to the therapeutic side.
Okay.
How is coronary artery disease therapeutically different for men or women?
There was a study, the Women's Health Study, that was published a few years ago that showed that aspirin has a different effect in women than in men. Do you want to go back to this later?
Yeah, we'll return to that. We just wanted to start out the topic of therapy. That's why you shouldn't leave the channel here. We're going to talk about treatment differences between men and women in coronary artery disease. This is Dr. Ogan Gurel with Dr. Annabelle Volgman, Insights in Medicine. See you shortly.
My pot of gold, your daddy's little girl, till heaven home.
It's easy to tell if you've had way too many. But what if you've had just one too many? Buzz driving is drunk driving.
Hey guys, thanks for coming.
Are we in trouble?
No, you're not in trouble. I just want to set some ground rules.
Like what?
Well, remember last week when you hit Vinny in the head with the shovel?
I do not recall that.
Of course not. Well, it was pretty graphic. Too graphic for the kids. So I'm going to have to block you.
I got to make this up to you. This is Vinny's watch, and I want you to have it. You deserve it.
Thank you. That's really not necessary.
No. Come here.
Welcome back. I'm Dr. Ogan Gurel with Insights in Medicine, brought to you by InTimeTV. Our guest, Dr. Annabelle Volgman of the Rush Heart Center for Women. Just before the break, we were talking about the therapeutic differences manifested in coronary artery disease between women and men, and just starting the discussion on aspirin.
Yes, aspirin. The little aspirin that can cause a lot of good for everybody can also cause a lot of bleeding, so we have to be careful who we give it to.
Yes.
I mean, I think aspirin should be a prescription drug, actually.
We're talking about 81 milligrams, basically.
We're talking about different doses, because it's different for men and women, and it's a big conundrum in medicine how much to give.
Tell us
to
more.
whom. Okay, so you know the Physicians' Health Study came out in the 1980s. We all recommended it to men over 40. They start 2 baby aspirins to decrease the risk of heart attacks, because it showed a decrease in heart attacks. Slight increase in hemorrhagic strokes, however. So that was always a caveat. Interestingly, 20 years later, we find what aspirin does to women. It's 10 years later.
Similar to the Framingham study lag.
Exactly.
Yeah.
But this is 20 years later, so it's long needed. And what we found in this big study that was done by the Brigham and Women's Hospital was that women over 65, even if you're low risk, they benefit from a baby aspirin, and it's actually smaller than a baby aspirin. It's 50 milligram dose.
Does such a thing exist
No.
on the shelves? Okay.
Not in the United States.
Yeah, right.
But if Bayer is listening or St. Joseph is listening, they need to make a 50 milligram dose. So women over 65 years old, whether they have risk factors or not, should be on a baby aspirin, okay, or 50 milligrams of aspirin. Under 65 years old, over 45 years old in women, so 45 to 65-year-old women, there was only a slight decrease in stroke risk and no decrease in heart attack risk.
Mm-hmm.
None. So
it's really not useful for that cohort.
In a low-risk patient, so
Yeah, of
or
course, low
no-risk patient women, if they're under the age of 65, they should be told this isn't going to decrease your risk of a heart attack. It slightly decreases your risk of a stroke, but there are some risks of bleeding every time you take an aspirin. So it's a hazy recommendation whether we should be giving it to low-risk 45-year-olds. Over 45, over 65, definitely.
But at a lower dose.
Lower dose. Now, high-risk patients.
Sorry.
Yes.
Yeah.
High-risk patients, the recent recommendation by the AHA that was just put out in 2007, February of this year, is that the high-risk women should be on 325 milligrams. So I continue 80,
which is higher than the
which is higher
than the
yes.
double baby recommended for men.
But that's primary prevention.
Okay.
So for secondary prevention, I think most people should be on 325 unless they're on other drugs such as Plavix or Coumadin. Yeah. So again, we need to make sure that they're not overly anticoagulated and overly platelet inhibited.
And so how about once beyond the preventative, well actually, in terms of the preventative, are there any differences in terms of statin recommendations? Obviously, notwithstanding the difference in triglyceride significance.
Right.
But once that's taken care of, in terms of administration of statins to women, are there differences?
No, there are no differences in recommendations in terms of lowering the LDL. But what I can tell you is women don't tolerate the statins as much as men. And I will get more women complaining of muscle aches or liver problems than men.
Are the actual mortality rates, actually really bad risk factors with statins more in women, or is it just these are more the subtle complaints?
These are subtle.
Right.
Subtle.
So the actual morbidity risk
from rhabdomyolysis,
and so forth,
which is very rare
of
anyway.
Of course, yeah, 1 in a million or whatever.
I don't think there's a gender difference, but I have not looked into that specifically. We did a study at Rush which looked at whether women actually have more adverse effects than men to the I call them four fabulous drugs of coronary artery disease: aspirin, statins, beta blockers, and ACE inhibitors.
Mm-hmm.
And because in my experience, it seems like more women complain of many different side effects than men. So we did a regimental study looking at whether they really do. And we found that there was really no major adverse effects. There was a trend, but no statistical significance. But what we did find were that women were still not treated as aggressively for their lipids. There were a lot more women with coronary artery disease not on statins than men.
From a compliance perspective.
Not compliance, but being offered the drug.
Right.
So I think we really need to be careful that we are checking off all the drugs that all these people need. So a diabetic woman is a CAD equivalent, and they should be on all those four fabulous drugs unless there is some contraindication.
Asthma or something for a beta blocker.
Right, exactly.
In terms of the interventional therapeutics for women versus men, or I should say versus,
yes.
It sounds too confrontational. But in terms of the interventional therapeutics for women as compared to men, are there differences?
Yes. If a woman has coronary artery bypass grafting, they tend to have it a little bit later. They're older, so they have more comorbidities, and they have a higher risk of dying from a CABG, from coronary artery bypass graft. So yeah, they have a slightly increased risk of dying from open heart surgery. However, angioplasties, no significant difference. Women do just as well as men in terms of angioplasties.
In terms of the circumferential deposition in women, would that argue that it's actually easier to do angioplasties for women?
No, because then no one's going to do an angioplasty in the circumferentially.
Oh, exactly. They're not diagnosed.
That's right, exactly.
Right.
But they tend to have smaller arteries. When stents were first created, a lot of women couldn't have stents because they didn't make them small enough for the women's arteries. But now they come in many different sizes, and I don't think that's a problem at this point.
One of the interesting aspects, and we can get into this as a segue into the biological differences, but estradiol has a protective effect on the vasculature. So why don't we get into that right after the break?
That's controversial,
I know it's controversial.
So let's talk about that.
So let's talk about that. It's Dr. Rogan-Gorel with Dr. Annabelle Volgman, and one of the world's experts in women's heart health. And we're really pleased to have her, and we have more to come. Stay right there.
Family and friends can provide the support you need to reduce your risk of cancer, diabetes, heart disease, and stroke. Eat right and get active.
Impossible. It's never too early to start reading to your kids.
Are you prepared for what awaits you?
There are amazing possibilities when you open a child's mind to reading. Log on to the Library of Congress website and let the journey begin.
Welcome back. I'm Dr. Rogan-Gorel with Insights in Medicine, brought to you by InTimeTV. The topic is women's heart health with Dr. Annabelle Volgman. Just before the break, and perhaps to generate a little controversy, so you'll stay there, we were talking about estradiol and its protective or controversially protective effect on the vasculature. Let's do that as a segue to talk for the next few minutes about the biological differences that may underlie some of these differences.
There are a lot of biological differences, but let's talk about the estrogen and hormone replacement therapy. That was the big deal in the 1980s and 1990s. As you know, the Nurses' Health Study, which studied over 40,000 nurses in the Massachusetts area, showed that there is definitely a decrease in morbidity and mortality in terms of cardiovascular disease in women taking hormone replacement therapy. So there was an assumption that hormone replacement therapy decreased heart disease. That was an assumption, and that was a bad assumption.
And the hormone replacement therapy was predominantly estrogen?
Well,
or was it mixtures?
And progesterone in the people who still had uteri.
So that, okay.
So it's a combination. So it's both.
Right.
So what the drug companies did was, in the HER study, they took high-risk patients, women who've already had heart attacks or have already had diagnosed coronary artery disease, and they randomized them to hormone replacement therapy versus no hormone replacement therapy. And for the first 2 years, there was a definitely increased risk of heart attacks and strokes in the women given the Prempro. And it was specifically Prempro. Okay? And 2 years later, the difference stopped. So the thinking was maybe it's just in the first 2 years, maybe we'll see a difference after 7 years.
A
But they
protective
stopped
effect after 7 years,
of
yeah.
hormone replacement therapy. But after 5 years, there was no, actually, there was a slightly increased risk of giving these patients Prempro. So they continued the study as, they warned the women, but they
Yeah.
continued them after 7 years. There was still no benefit from Prempro
And in fact, to
terms
some
of decreasing cardiovascular morbidity and mortality.
and because of the first 2 years, in a sense, there was an increased risk
That's right.
overall.
So they said, well, maybe this effect is only in women with coronary artery disease. Let's look at women who don't have diagnosed coronary artery disease, and that's the Women's Health Initiative. Huge NIH study, studied hundreds and thousands of women, and they randomized them to hormone replacement therapy, and again, using Prempro or just Premarin. Same drug, same formulation, and again, there was no benefit. There was a slightly increased risk of heart attacks, strokes, breast cancer,
Right.
and
It's
blood
somewhat-
clots and pulmonary emboli.
And some minor protective for
Minor
colon
benefit
cancer.
for colon cancer and osteoporosis,
Right.
but it did not offset the
Right.
more devastating diseases. So as a
So what is
result of
the,
that,
what is the consensus now?
the consensus is don't use Prempro for preventing heart disease. We never, ever use hormone replacement therapy to prevent heart disease.
Yes,
We
of
don't
course.
use it as a secondary treatment, so that's what came out of it. But there are a lot of women out there who are very symptomatic from their menopause, and what we're doing now is doing studies in different formulations of estrogen, and there may be some benefit that we're seeing. I think it's too soon to make any conclusions about which drugs are beneficial. So for now, in symptomatic patients, I say, let's make sure you don't have atherosclerosis. And if you don't have significant atherosclerosis, if you're really miserable with your menopausal symptoms, go ahead and take some hormonal replacement therapy for maybe 1 or 2 years, and that's it.
Right.
Because most
get over that,
menopausal symptoms
situation.
go away after 2 years anyway.
Right.
So why expose them to those risks?
And to some extent, you tailor that to the risk profile
Absolutely.
of the patient, the woman. Why don't we talk a little bit about the Rush Heart Center for Women?
Okay.
We talked a lot about, I know you would, it's one of the pace setters in building this understanding and, of course, serving the needs of patients. We talked a lot clinically. What are some of the practical aspects? Tell us a little bit, very short, about the history and how that's played out.
Well, as I said, I've been practicing for 18 years at Rush University Medical Center, and as an electrophysiologist, I saw a lot of women whose palpitations were misdiagnosed by other physicians as stress-induced, anxiety-induced, and just take some Xanax and go away.
Supratentorial, as they say.
Yes, exactly. And these women were very frustrated, and so some of these women were fortunately referred to me, and I diagnosed many different kinds of arrhythmias in them,
Yes.
and were able to help them with either drugs or catheter ablation or just really stress reduction. You can tell a woman in many different ways that they're just stressed out, but to tell them, oh, this is all just stress and just leave me alone, but to actually work with those women saying, well, let's make sure you don't have heart disease first, and then let's look at what's going on in your life. And that goes very far in terms of building a patient-physician relationship.
So to some extent, those stresses, the supratentorial factors,
Do contribute.
were significant.
Absolutely.
But as they always say, supratentorial issues, psychiatric issues, psychological issues can be significant, but it's dangerous to rely on those in case there are physical issues.
Yeah, I always rule out heart disease
Yeah, of course.
first and then figure out what's going on, and it's really good for the patient-physician relationship.
Right. Tell us a little bit more about the Rush Heart Center. For example, we have potentially hospital executives watching the program. So how is it structured? Tell us a little bit about that. What is it?
Well, Rush has been very supportive of this. partly because I have taken care of the mothers of some of the executives at Rush and who have heart disease, so they believe in this.
Yes.
And I think it's very timely to open a heart center for women, especially with the increased awareness of heart disease in women. And there are more women dying of heart disease than men, so we really need to take better care of them. And we need physicians who will really try to understand the differences and who will really try to work with these women to try to decrease their risks. So what we did was we made it more inviting for women to come to a place where they are going to be listened to. There are only women taking care of them. We have nutritionists, and at one point we had a cardiac psychologist, and it was really very helpful.
Well, sounds good. We'll be right back. This is Dr. Ogan Gurel, our guest Dr. Annabelle Volgman of the Rush Center for Women, and stay right there.
This is fine. Thanks.
Welcome back, Dr. Ogan Gurel. We are nearing the close of an outstanding session with Dr. Annabelle Volgman, Professor of Medicine, Cardiology, and Director of the Rush Heart Center for Women. We've been talking about heart health and mostly focused on coronary artery disease, which has significant differences. I think this is a very informative hour. We talked about the differences in risk factors between men and women with respect to coronary artery disease. We talked about the differences in diagnosis, the differences in therapies. We had started out with a quote around the Framingham study, in which there was a lag between the appreciation of the substantial burden of coronary artery disease on women. We're nearing the end of our show. This has been incredibly informative. I know that there are other diseases that are specific heart diseases to women. Tell us a few of those.
Well, some of the women that we've seen also are women with broken heart syndrome. That is more common in women than men. Mitral valve prolapse is more common in women. And again, peripartum cardiomyopathy is only in women.
Yeah,
so these are women who are pregnant and they develop heart failure. So those are just some examples.
Well, you've been a fabulous guest, obviously one of the world's experts in women's heart health, director of the Rush Heart Center for Women. I would hope that we'll have a chance to have you again to talk about some of these other aspects of women's heart health. Obviously,
be happy to.
And, well, we'd be happy to have you. So thank you so much. And you're welcome. This is Dr. Ogan Gurel with Insights in Medicine, brought to you by InTimeTV. Another great hour. Our guest, Dr. Annabelle Volgman. We'll see you next week and look forward to it.